Hi, everybody. This is Jonathan DeMonte with the Bowen webinar. All Bowen, totally hip. And so it's not only about hip pain and hip problems, but a big focus on that. So anyone who was earlier in the live webinar, my apologies. Apparently, I don't have the bandwidth for streaming. I'm using Starlink, which is, Elon Musk's web system, internet connection, and it just was not good enough. So again, I apologize. I do, however, have the questions, and I'm going to answer those as I go through the webinar. So, all Bowen, totally hip. So, what are we going to cover today? We're going to cover intransigent hip issues, a bit of a question and answer, which is not going to be live, but at least it's post live, and then a little talk about Bowen associations and registries. So I'm broadcasting now from the Cowichan Valley near the city of Duncan on Vancouver Island. I'm here as my eldest daughter just gave birth to a beautiful baby girl, and it's super nice to be here in Canada because I've been away for some time. And you can see there's still some snow on the ground. This is just a picture from this morning. This is the tiny house on the farm, and I'm actually in that cabin as I speak. So, yeah, just a quick note. I've been busy. I've been living in Mexico, and now I'm back in Canada for a couple of months. I'm going to help out here on the farm and with the new baby, so it's a real pleasure to be here for that reason. But I'll also be doing a couple of Bowen therapy courses, two in BC, in the Lower Mainland in Tawasin, and then a couple in Mexico. So those are happening in March and April. And some of you know I've produced a new online course named Homeopathy Simplified, a course for body workers and everyone else. And I'm really proud of how well it's turned out, and I hope you get to take a look at it later on. Now that it's completed, I can focus a little more time on Bowen therapy trainings and promoting Bowen, hence this webinar. So hopefully you get something good out of it. It's a topic that has been in my eyesight for a while now, and that's because of how many hip problems I've been treating. So we've all had, cases of hip and low back pain and groin issues that have been hard to resolve. And so we'll talk about identifying some of the causes, how to assess them, and treatment options. And I've made a little list of those issues that I want to cover. So we'll cover osteoarthritis, greater trochanteric pain syndrome, SI joint syndrome or pain, lumbar facet syndrome. This is a very important syndrome to talk about. Pelvic instability, hip impingement, and Iliopsoas syndrome. So what are these? And we'll go through them a little bit and just identify some of the symptoms and the causes. So on the screen, you'll see a list of symptoms for osteoarthritis of the hip to start with. So you can see that these are all pretty classic hip joint syndromes. Stiffness waking, difficult to get moving in the morning. The mobility of the hips movement is limited in all directions. That would be one of your assessments. This is because there's bone-on-bone contact. Pressure onto the front of the hip joint can be painful, and they have a lot of limited strength, lifting the legs sideways for abduction. So those could be some of your diagnostics. In fact, one of the main ones is to lay the patient on the table, on their back, bend their knee, and have them press against you hold their thigh at their knee and you have them press outwardly with that knee. And that could bring out the pain and be a very strong indicator that it's osteoarthritis. But why? So the hip joint consists of a ball and socket, the acetabulum. And so here's the femur going into the socket of the pelvis. Now both those connectors are covered with a layer of thin cartilage. That's a shock absorber and ensures smooth movement in the joint. So basically osteoarthritis is the deterioration of the quality or the content of the cartilage. The result in the joint moving less smoothly and shocks being absorbed less effectively. Then the wear and tear of the cartilage can result in chronic hip symptoms. So this loss of cartilage means that the bone structures in the joint increasingly come into contact with each other. This is painful, and the joint becomes less mobile as a result. In response to this process, the body may start to form osteophytes. That means abnormal bony growths occurring along the edges of the joint, making the joint wider. So the body's answer to the pain of the loss of cartilage is to make the joint wider and distribute the pressure over a greater surface area. That's simply it, and that's the osteoarthritic process. So we'll talk about treatment options at the end of the list of these syndromes. So the next one I want to talk about is greater trochanteric pain syndrome. So the trochanter is, here's the femur, and it's the bend of the femur before it turns into the socket of the pelvis. And essentially it is about two bands of fascia that run from the glutes through to the knee. So the iliotibial band is a large band of connective tissue that runs from the pelvic ridge down the outside of the upper leg to the knee. It passes the greater trochanter along the way. The pain that is there is caused by damaged or irritated structures that move over or along the greater trochanter. So these two muscles are emanating from the gluteus maximus and the tensor fasciae latae, the TFL, and those are what are rubbing over the hip joint. So when you have a misalignment in the posture, in the pelvis, in the joint, the way it's seated into the acetabulum, that will cause a friction at the trochanter between those two muscles, and that creates a bursitis. And that's why we need to correct the posture in order to reduce the inflammation that is formed there. And that inflammation is called a bursa, and that becomes an inflammation, a pocket of inflammation between those muscles. So very common issue, and of course medically they would give you a cortisone shot there, and that would reduce the inflammation. But as therapists of Bowen therapists, we want to reduce and eliminate the cause of this. So some of the symptoms are a tendonitis in the hip abductors. So that could even be the outer thigh, the vastus lateralis, the inner thigh, the adductus longus. So all of the procedures you would use, all the muscles you would use in the procedure of the pelvic procedure. So that gives you a number one clue about the pelvic procedure. Okay, so SI joint syndrome, so the sacral iliac joint. It could be because of hypomobility, so too stiff a joint, or hypermobility, too mobile a joint, and or most likely damage or strain to the joint ligaments, and that will produce the syndrome known as sacral iliac syndrome. And these could be caused by an accident or even just a misstep on a stair or a pavement. It could be from an infection, a malignant issue, but most likely pregnancy and or repetitive movements in the sacral iliac joint. So one-sided sports activities, tennis, golf, even weightlifting, etc. If you have a small misalignment and you're straining this joint, it's going to cause inflammation in those tendinous attachments, the ligaments especially. So, it can present as a lot of pain. The pain can be in the same localized area of the buttock, and or it can radiate into the thigh, and so it can be a very problematic injury. You've all probably by now had a patient rise from the table, have them walk a little bit, and then performed the sacrum procedure, and seen how quickly that problem can resolve just from releasing the tension in those ligaments that contain the posture of the sacrum. Okay, so you can read those syndromes. Now this is one that you may or may not have heard of, and it's called lumbar facet syndrome. And this is where the facets of the vertebrae become misaligned, or the ligaments and tendons attaching to them become strained or injured. Now, that could be as a result of some form of degenerative back issue. Could it be from a bulging disc, a ruptured disc, a sciatica that was, not fully resolved, back strain, of course, and then most likely degeneration is a big part of that. You've all probably worked on someone's back with the BRM basic relaxation moves 1 and 2 of BRM 1. And those are in the lumbar at around L4, L3, L4. And when you do those moves and you hear an adjustment take place in the spine, that's a very good indication that there is some issue going on in the connection of the tendons to the facet of the vertebrae. And so you'd be looking at this syndrome. In fact, how they diagnose it is they use a nerve block to take away the pain. And if the nerve block at those vertebrae takes away the pain in other areas of the hip, such as the groin or lower down in the sacrum or in the piriformis area, then you diagnose this problem. So you do see, a lot of symptoms that could be misleading to you. So you have this one-sided pain, definitely pain on stretching or arching the back, pain when, excuse me, I'm just going to check my phone. And then, pain when turning the back, for instance, to look over your shoulder. And then, more importantly, the pains may radiate to the groin, front or side of the thigh. They might feel a constant pressure in the lower back, and then it's better for bending forward. So that could be a very important indication of how to treat this problem. And then, of course, there's lots of muscle tension in the lumbar, and then any activities, running, swimming, etc., could provoke the pain. So that's a little bit about it. Often it's a result of, for instance, sleeping on one side only in your bed could adjust your posture enough. For instance, if you were sick with the flu and you lay for a long time in one position, that could definitely cause this sort of misalignment in the sacrum and thereby the back. So now we'll talk about pelvic instability. So this is basically where you would have all sorts of pains: lower back, coccyx, abdomen, thigh pain, in the groin or in the pubic bone itself. You'd have difficulty walking, going up and down stairs, turning in bed, getting up from a chair. Any jarring movement would be very aggravating. Pains during your menstruation or with intercourse, and then any starting pains where you get moving and there's a lot of pain from being sitting. So, for instance, driving, etc. So anatomically, the pelvis is 3 bone segments: the left half of the pelvis, the right half of the pelvis, and the sacrum between them, which is wedged in those 2 halves of the pelvis, like a point stone in the arch of a bridge or a window. And you see that pelvis having a slight misalignment, and the sacrum has to also compensate. They have a lot of ligaments connecting them. And so those ligaments can hold the tension and protect the joint, but keeping it locked in this misalignment. Okay, so Not much more. I think, pregnancy and childbirth is always a very big cause for women. As even from many, many years back, you can, almost predict the cause of this problem. So hip impingement generally affects younger people, and it's basically a constriction in the ring of connective tissue of the hip cartilage, and it becomes almost trapped and making the joint very stiff. So there's three types: cam impingement, where the femoral head is too wide, so it doesn't fit into the socket, or pincer impingement, and then the hip socket has a defect itself, such as an osteophyte or something misaligned. So this again is really an alignment issue. It should resolve with proper alignment. When your hip joint is slightly rotated, it can cause a lot of different problems. So the third diagnostic term is combined impingement, where both syndromes are present. And then finally, I'll talk about iliopsoas. So this is the psoas, the core muscles that we're talking about. And in this, you can have many, many symptoms that we've already mentioned. Groin pain, running along the front of the hip. And then often you'll hear the patient tell of their hip snapping. And those are the ligaments perhaps rubbing over a ridge of bone in inappropriate alignment. They can't bend properly, difficult. They post to one side when they stand. They even sit to one side. It could be a result of, having sciatica is a common issue, and that could come from just a simple back strain, and then never really, recovering, where their core was never balanced and it was remained in a asymmetrical posture. So, in Bowen, we look at our patients oftentimes before we treat them, and we look at where their thumbs are positioned in relationship to their thighs. So if there's a misalignment from where the thumbs or fingertips sit in the thighs, you can assume that there's a core misalignment happening. Okay, so let's go through some of the treatment options for these conditions. And I'll talk mostly about Bowen treatments, but a little bit about others as well. So for osteoarthritis of the hip, we have, a basic treatment of pelvis and sacrum. And these really should be, in my mind, one therapy. And I think if you do pelvis without checking to do the sacrum, you're missing out on affirming the alignment of the pelvis and sacrum. And then doing that and assessing the response. Of course, there's a jumble of therapies that could be utilized and useful for the treatment of these conditions. And I would suggest that, you can easily, do pelvis and sacrum and then assess the result of that, giving it that week or even less number of days than that if it's appropriate. So greater trochanteric pain syndrome, treating a trochanterial bursitis. There's a couple of extra procedures on top of pelvis and sacrum that you'd consider. One of those is called straight up the leg, where you start the procedure with this one-sided leg procedure. And that's a wonderful way to start. And sorry, my computer is not letting me scroll, so I can't see what I've written. So straight up the leg, pelvis, sacrum, and then there's another procedure called the bursa, a bursa procedure. So that's where there's a small procedure around the circle of pain that you would look at applying. So the bursa or bursitis procedure, as it might be called in your schooling. Then we've got SI joint syndrome, SI joint pain. So we've got a procedure called the sacrum release. Now, if you haven't used that or haven't paid much attention to it, it's a very, very valuable procedure that is done on the sacrum at the edge of the bone and against the ligaments of the gluteus maximus where they insert. So it can release that tension in those ligaments and allow the pelvic procedure and the sacrum procedure to work. And then, of course, you could assess um, for this SI joint pain with the coccyx procedure, because you can assume that if the sacrum is out, most likely the coccyx is as well. And it doesn't mean you have to do the coccyx that session. Remember, you've got lots of time to work with these issues and unravel the mystery and puzzle of the syndrome itself. So when looking at the condition lumbar facet syndrome, we would do the same. The sacrum release, the pelvic, the sacrum, assessing for coccyx, but we'd also, at a later visit, consider the psoas, and then also a procedure called the lumbar release, which is a series of Bowen releases across the iliac crest. Then, I did mention about having that self-adjustment occur on one side of the spine when you do BRM1 moves 1 and 2. Very good indicator for paying attention to these procedures, all of these procedures. And I think it's rare as a Bowen therapist that we wouldn't reach for these basic hip joint procedures. Pelvic instability, we've got the same again. Pelvis, sacrum, coccyx, and also consider psoas procedure, and another procedure called the iliacus procedure, and then another called gracilis. All of them are inner pelvic and inner thigh procedures. Basic hip impingement, we've got again pelvis, sacrum, and coccyx, but you might consider hamstring and or deep sciatic if the piriformis is involved or inflamed in any way. And then finally, Iliopsoas syndrome. We don't, of course, do the psoas procedure. But what are the prerequisites of the psoas procedure? They're the kidney procedure and the respiratory procedure, moves 3A, 4, 3, 4, and 5. So those moves on the front of the diaphragm and rectus abdominal muscles. Then again, on the thigh for iliopsoas, we've got what's called the quadriceps procedure or the rectus femoris procedure, which is those way of releasing those anterior hip flexor muscles. So, it's not that Bowen is the only thing that will help these people. You might want to add in, some basic supplementation options like serrapeptase or bromelain or turmeric or even vitamin C, just these natural anti-inflammatories, or an ointment as well could be very helpful. Tromil or arnica cream or boswellia cream, anything that would be an anti-inflammatory, especially in things like the trochanteric bursitis or groin pain or even sacral iliac pain. These could benefit the patient. And then other options are more medical, things such as ozone injections, PRP, the plasma that's spun from your blood donation, or even stem cells. And for me, I'm a homeopath, so I'm using homeopathy for these kind of conditions because I want to give my patients something in between sessions to help release the pattern that they're holding, that old pattern that they slip back into. Once you start unraveling this, it's an important process. So let me look at some of those procedures that I talked about and just to really briefly go over them. So we've got sacral release procedure. This is a series of Bowen therapy moves along the edge of the sacrum and on the edge of the gluteus maximus where it inserts and attaches to the sacrum. So this can be very important. It's done lying down, whereas the normal sacrum procedure is often done standing. So in my demonstration on the video, I think I do 2 directions. So just make sure you're symmetrical and do your directions on both sides of the sacrum equally in the same direction. And you can go in either direction. Now, there's some, talk about what identifies which direction, but if you go in the wrong direction, don't worry. But, Bowen is very forgiving, as you know. Then I'm going to go to the pelvis, and I want to just mention about the pelvis procedure. One of the things that I've come across in my practice is that people will often have been to another Bowen therapist and then come to me, and they do distinguish the style of Bowen therapy. They absolutely do. I'm not giving any judgment of which is what, but I want to emphasize that my method is definitely to work the muscles. I do want to sink down beside an edge of muscle and put the tension into it so that it releases. And I know there are the style of Bowen therapists who are more surface and just working with the fascia. I know that they both work. However, I think that from many customers, they do say they get better results with that true release of a structure. So, you don't have to play the muscle hard to release it, but you do need to release it. Just doing the moves surface on the skin is so different than actually putting a bit of tension and then releasing the tension. That's the difference. Anyway, so these muscles all need a good release. So whether it's vastus lateralis, adductus longus for move 2, sartorius for move 3, take the palpation, do the palpation, take the depth, put the challenge, and move through the structure so that it escapes your challenge. And then even a soft move like the inguinal ligament of move 4, you are going to be on the muscle or the ligament, and you do press onto it. You put the challenge and then release. So it's not just an airy skin move. You'll get more effect with actually playing the structure that is identified as being the move. So that's my little lecture about that. So another one is the sacrum procedure. So invaluable procedure. We underestimate its worth because to release the movement of the sacrum is going to allow their body to fully respond after the session. And if you see them walking and they are still posting to one side more than the other and they're stiff on one side, you do need to release it. And you should get practiced at seeing the difference that it makes, both in their gait immediately after you do it and then over the days that follow. So that's the sacrum. And then psoas. I want to mention about psoas as well because I know it's a difficult picture to see and maybe I could find something better to look at. But the point is to go deep enough. Yes, you're going to feel the pulse of the artery. Just adjust your finger, either deeper or laterally away from it. And once you do that and fully challenge what your fingertip feels, you can make a little move over that series of fibers of the attachment of the Iliopsoas in the groin. So that's it. And then one more procedure that was wanting to be talked about was the iliacus. So iliacus is the, if you can see on this picture on the right, you can see that there is the inguinal ligament running to the front. And there you see the ASIS, the anterior superior iliac spine. And what we want to do is take our middle finger and go adjacent to the bone and deeply into the pelvis and challenge and release. It's not a move you feel much. They will feel such sensitivity there. The point is to send the message to that structure. And one tip for this move is to have the patient on their back, knees bent so that the abdomen is more movable. You can get into the inside of the pelvis that way. So to do this, I would stand above the hip, superior to the hip, and reach down and then use the finger to release. So this could be another important procedure to help the pelvis release its one-sided posture issue. And I'm just going to quickly look at the question and answers. I've got them here. So that I can, so thank you all for being in attendance, and I'm sorry that there was a bit of a cock-up. Okay, so one of the questions I had was from a practitioner, a student, new practitioner in Ontario, and she's really a little bit lost in terms of having support, and that has to do with, the lack of a governing body. And I know that there is, a couple of registries. I'm affiliated with the Bowen Canada, and Bowen College, Manon Bolliger and I are actually in talks of how to blend those registries so that they could be supported. But really, either one of us doesn't want to be involved in that. We want to be teachers. That's what we do. And it's necessary now to see a practitioner-led organization take over those roles of creating standards for the profession, supporting the promotion of the profession, and running those registries and getting the word out about Bowen therapy. So if anyone wants to reach out to me about that, please do. And that could be an international effort as well, because, the US is in the same boat as Canada. The UK now has a wonderful practitioner association making great headway into this issue. So something could be done internationally at this point. So I'm very happy to help out and put people together, but I am not in a position to do that. And, unfortunately, the profession has been led by all the different schools and teachers, and of course, they haven't always gotten along. But nowadays, we're all getting a bit more mature and behaving better. So that's about that. And then a couple of the questions. Let's go through those. So someone said they had a knee replacement, and would hip protocols be better at first? Well, no, I think you still want to address the chief complaint, and that would be to give relief to the inflammation of the knee. Even though it's had surgery, those tendons and muscles still need the treatment. And of course, you're going to look at the body holistically and see that if there is a hip alignment issue, you're going to probably do pelvis. That would be very common. And maybe hamstring. All those misalignments from having one-sided knee pain can be a reason to look at the hips. So another question was about neuropathy, and someone wanted to talk about the neuropathy of the hip. So I would suggest that, when we talk about neuropathy, we're often talking about the coccyx and then the deep sciatic and or buttock pain procedures are very important. But you'd preface those with pelvis, most likely, until you're sure of the symptom and therefore sure of the protocol to use. And I think that's about it. Unfortunately, for those who were on the original webinar, okay, here's one. I will be a client with neuropathy in the left leg after back spinal surgery to put a rod in it. Pin discs, lots of pain. Well, you've got to start in a situation like that with the low back. And of course, if the syndrome refers to the leg, we have to consider those procedures for the leg as well. So it might be, depending where on the leg, if it's the thigh or the calf itself, we might be looking at burning heel. We might be looking at deep sciatic. Those are the neuropathic pain procedures. But most definitely, BRM1. I mean, BRM1, pelvis, sacrum, psoas, these very basic procedures are respiratory. Don't forget that. Kidney for the quadrus lumborum muscles. Kidney is definitely part of the back and the hip. So quadrus lumborum is not to be ignored for back pain or hip pain. So fortunately, we've included that in the prerequisites for psoas. And one of the things I mentioned in the earliest seminar was about time. Some of these procedures, I mean, if you haven't had a Bowen therapy session in a while as a practitioner, slow down and have one. Because when you allow the pauses to take effect on and respond to these procedures, you will be freshly amazed at the efficacy of this procedure, of this therapy, that it does require time. And when the procedures require a long pause, give a long pause. Just do less procedures and give a long pause. So that's why doing so many procedures all at once is just never going to be as effective as being more selective and allowing the time for them to process. So that's about it for what I have to say. So just a couple of other things on the slides. And one of those is about just the courses. If you're interested in the next Bowen therapy course, it's taking place in March. And then this code, Love to Learn, gives a discount for the course. And so you can get that at bowen-online.com. And then lastly is the address from my homeopathy simplified.com website with the course information. And I hope some of you, get around to looking at that. So thanks again, and I apologize profoundly for not being live, but at least the recording is not the worst. Okay, take good care. See you soon.